Good morning to everybody. I would like to introduce myself. My name is Mario Bezzi and I come from the University of Rome in Italy. I am at the same time the moderator and the speaker of this session. This lecture is the first of 5 lectures on a basic course in interventional radiology, and the first one is a lecture on needle biopsy. Since this lecture is also part of the chest program, I was asked to focus mainly on lung and mediastinal biopsy. So if you want to take a seat, please, we can get started. When we talk about lung and mediastinal biopsy, there is a list of items that we have to consider, and these items will be the topics of my lecture. We will talk about reviewing of the imaging, indication and contraindication, the selection of the type of guidance that we prefer, how to obtain consent, local anesthesia, the biopsy itself and auxiliary techniques, and how to manage complication and the recovery period. So let's look, for example, at this patient. This is a lady, she's 77, she has COPD, she's a smoker, and she has scleroderma. She's having a cough for the last 2 months with 1 episode of hemoptysis. She's taking a chest X-ray and she has a density in the right lower lobe. And from these 4 images, you can clearly make a diagnosis that this is probably a lung tumor, probably a stage 3A lung cancer. But where do we get a tissue diagnosis? We can get it from mediastinoscopy from the lymph nodes, bronchoscopy. We can try to sample the thickening of the lower bronchus, transbronchial biopsy, or percutaneous biopsy. So there are several ways to obtain tissue diagnosis in this kind of patients. And of course, radiology plays a role. When we think of the most common type of lung cancer that we are going to find in this kind of patient, you have on your left a list of different types of cancers, the most common being squamous cell carcinoma, but with adenocarcinoma, as all you know, on the rise, either in non-smokers and in smokers, and other variants which are more rare. Before, we had only first, second, and third line of chemotherapy, but now that we have prognostic factors and molecular markers, we are prone to use several other drugs, which are monoclonal antibodies and tyrosine kinase inhibitors. And this kind of molecular factors are usually found by this gentleman over here. And this gentleman over here is able to give not only a tissue diagnosis, but also a prognosis of the tumor of the patient if we get enough tissue or enough cells. So there is a question that we have to ask ourselves. Percutaneous biopsy will be followed by definitive histology or not? Because if it will be followed by definitive histology because the patient will undergo surgery, at that point our diagnosis is tumor, non-tumor. But if the biopsy that we do will not be followed by surgery or definitive histology, but will send the patient directly to chemotherapy, at that point the molecular markers and the prognostic factors become very important. Having said so, we are in our department and we are asked by one of our colleagues to do a biopsy on a patient with a tumor. The first thing that we do, we want to review the imaging. Because by reviewing the imaging, we see if there is indication to biopsy. We select the guidance that we want. We plan the procedure. We schedule it. We decide if we want to do as an inpatient or as a day case procedure, which is very, very important. And while you do that, sometimes you will realize that your biopsy is very, very easy because after 4 weeks of antibiotic therapy, that nodule is gone. And that nodule was a small pneumonia. How many times do we see that? We see that things that we wanted to biopsy and they were scheduled for biopsy are actually changing, okay? Most of the time you will see that the follow-up images are of poor quality because in the biopsy procedure we'll use a low-dose setting, so the quality of the lung windows is noisy, so you will notice that. How about this nodule? Okay, it's scheduled for biopsy. Then one of my residents did a very careful search in the PAC systems, and he realized that the nodule has been there for 20 months with no change. This patient is scheduled for follow-up, not for biopsy. This is another case. She's a lady with breast cancer. She's a long-time history of breast cancer. She's done a PET-CT with these densities over here with an uptake. Scheduled for biopsy for histology because they want to know the prognostic factors of this lady. And this is the low-dose initial scan for biopsy. And this is the follow-up at 8 weeks. And these were focal density to pneumonia, granulomatous pneumonia. Contraindications. Once you have decided that there is an indication for the biopsy and you are going to schedule it, then you go into clinical part of it. I think that the only contraindication, the only real contraindication for lung biopsy is no consent, either from the patient or if the patient is not able to give consent from the family. Otherwise, the other contraindication that you see listed here, there are ways to go around that. First of all, the main problem is the coagulation status of the patient. And of course, you can a little bit change it. You can use a small needle. If the patient is using full anticoagulation, you stop it. Or you may decide that there are no indication because the diagnosis that the clinician is asking is a diagnosis that will not alter the management of the patient. In that case, you're allowed to say, I'm sorry, I'm not going to do a procedure which is at risk of complication if the diagnosis that we are going to make is not going to alter the treatment of the patient. Of course, if there is no safe access, that comes for sure. Or, and this is a relative contraindication, if you have a patient who had surgery and he has only one lung, or he has functioning one lung because he has severe COPD, or he has a controlled pneumothorax, and you think that if you're going to induce a pneumothorax to this patient, you are going to be in trouble. Guidance. I started my work a long time ago, 1981, with ultrasound, and of course I am an ultrasound fan. And any time that I have a lesion that can be biopsied with ultrasound, I tend to do so because ultrasound guidance is very useful. Why do I do that? Because the CT schedule is very busy. The ultrasound schedule and the ultrasound that we have in the angio room are not so busy, so it's easier for me to schedule a patient which is feasible under ultrasound and do it under ultrasound rather than take a slot for CT. Ultrasound is easily available, easily repeated. You can see the sternum, the lung, the aorta, the lesion, and of course, it's less expensive than a CT. And this is a case that we did this week. Okay, this is an old man, this lesion, touching the pleura, abutting the pleura. It was scheduled for CT. But the CT schedule was busy. We had already 6 biopsies that day. So I said, bring him over to ultrasound. And this is the lesion. You do a prone, axial, and sagittal view. And this is the procedure. Quite easy. You see the needle coming over here. You see the lung. You go to an area where the lungs are not in the way, enter the lesion, see the needle, and fire with a biopsy gun. Of course, before you do that, you have to be sure that you can do that. This lesion looks very similar to the other one lesion that I just showed you. Okay? It's parasternal, close to the sternum. The internal mammary artery is well seen. This is easy. Okay, bring her over. You don't see anything. Lung is in the way, the sternum is in the way, the aorta is there, and maybe this is the lesion? No, I don't feel safe. I don't want to put a needle. So put a needle under ultrasound if you are confident with the guidance and you see all the anatomical structures that you actually see with CT. Okay? And you can do that. Of course, this was done under CT, and you see the biopsy over here. While you review imaging and you decide about guidance, you may find that there are relevant extrapulmonary findings that can be useful. Remember that in most of these cases, for example, in this lesion where you can have an approach from the left side, have an approach from the contralateral side, and of course, in both cases, unless you use some trick over here to open the mediastinum, you will cross the pleural surfaces, and you may need tissue diagnosis with the histology. At the same time, you're going to use a small needle because of the risk of pneumothorax. How these two things, balance out. But while you review the imaging, you see that he has an osteolytic met in the 7th rib. At that point, things change completely because the 7th rib is something that you can biopsy easily, get histology. You can do it with CT or with ultrasound. Now you have realized that I am an ultrasound fan. And you keep going. Another patient, central lesion. Are these lesions at risk of pneumothorax? For sure. 2-centimeter lesion, central, risk of pneumothorax is there. But he has adrenal metastasis. This is a stage 4 lung cancer, and you are allowed to biopsy the adrenal metastasis. I'm not going to say that every day you're going to see a case like this, but you have to review the whole CT scan and the whole imaging of the patient to rule out possible alternatives to your procedure. Consent. Consent is something that you don't like to get from the patient. You have to talk to the patient, you have to explain things, you have to explain the contraindication and risks, but it's the first step, probably the first time you see that patient, and is the first step to obtain the patient collaboration. The doctor performing the biopsy and the patient are a team. And if you don't team up, the biopsy will be probably more difficult. So this is the first step. Obtain collaboration, introduce yourself, explain what you're going to do. Of course, you have to explain the bad things, pneumothorax, hemoptysis, probably hemorrhage. Maybe I'm not going to get tissue and we have to reschedule you in 10 days. I'm sorry. Sometimes you have to mention even more rare complications, which are more dangerous. But anytime you do that, you have to look positive and confident. Never look shy, never look hesitating. You are a doctor, and he or she has to trust you because you know what you're doing. Okay? You have to tell the truth, but don't look shy. At this point, you can plan your procedure. It's about time. So you have to decide, where do I enter? Where do I go through? How do I put my patient? Why patient positioning is so important? Well, patient positioning is important because it's about everything. It's about placing the patient, the lesion, and your needle in the correct plane. So you need an entry site, which ideally should allow you to see the needle in one slice, if possible. Okay? You don't care about tilting right to left, but what you don't like is tilting caudal and cranial, because caudal and cranial will make you have the needle out of plane unless you tilt the gantry as well, which can be done, but is not the usual thing that we do. Patient positioning, supine. Unfortunately, what happens that in old people, and most of our patients are old, shoulder pain can be a problem, and cervical pain can be a problem as well. How many times have you seen a patient saying, "Doctor, I have pain in the shoulder"? No, don't move. We're just in the middle of the procedure. So you want to avoid that. So a possible solution gets the arm down, possibly blocked. This is very well tolerated. Like in this case, you see, the patient is blocked. Of course, with no shirt on, otherwise it's impossible to make the biopsy. And sometimes this will limit a lateral approach, but you realize that soon, right away. At that point, you can have one arm down and the other up, whatever you prefer. Prone position. Some people say that prone position is good because they breathe less, they move less, and they see less. They don't see the needle. That's what the doctors like. Okay? But unfortunately, again, we may have shoulder pain and cervical pain. So sometimes, you know what we do? We tell the patient, "Sir, you lie with your belly down. You find the position that you think you can hold for 20 or 30 minutes. I'm not going to tell you what position is the best for you, but you find a position. So they start moving. You can use pillows to help them out. You can have 2 arms down, the swimmer position, whatever you want to do so that the patient is stable. Sometimes you will have to use the lateral position, and you can stabilize the patient with pillows, sandbags, straps, the straps that you have seen before to hold the arms. Whatever you do, do everything you do to improve the patient compliance with the procedure. The patient, sorry to say, should be dead and stable. Okay? If he moves or she moves, you're in trouble. Breathing instructions. First, position. Second, you know how much you have to communicate with the patient. Okay? They're awake. You're going to get only local anesthesia. They're not sedated like when you do a TIPS. You know, you do a TIPS procedure, they're sedated. They don't care. Shallow breathing for upper lesions. They don't move very much. I prefer end expiration breath hold for lower lesions. Take a small breath, blow the air out, stay still, and you check it a couple of times. Okay? The prone position for sure reduces the lungs excursion, but you've seen where we may have other problems as of positioning. Give a clear advice that he or she has to follow the instruction even if she feels pressure or pain. Because at a certain point, she or he will have pain, and you want him to hold his breath the same time he did without pain. Altogether, remember to team up with your patient. Okay, breathing. This is an easy lesion, okay? You're there. Just in front of the lesion, you want to get a little more of local anesthesia, a little bit more up to the pleura. Whoop. What happened? It's breathing less. Okay, sorry, sir. Again, take a deep breath, blow the air out, and hold it. Up. Too much. Okay, it's like a video game, you know? But if you are convincing, of course, it depends also on the age and the mental state of the patient, his education, you will get collaboration. And of course, you will get a good tissue diagnosis. There are systems to help the patient breathe as you want. They're very, very tricky devices with the feedback. They have a belt, and when the light is on exactly on the same position, they can hold this breath. We have tried this, but to me it looks like a fancy tool, but I'm not sure it can be of use. Inform the patient that the local anesthesia will kill the pain, but not the cessation. Okay? So he will feel the needle going into the body. So this is a tactile sensation. It's not pain. Of course, when you reach the pleura, it will be pain. Okay? At that point will be pain for 1 second, because the pleura hurts when you traverse it, not after you have traversed it. Okay? So this is very clear. You're going to feel a sharp sensation, but don't worry, it will go away in a second. Okay? Because otherwise they move. Warn them. Okay? Let's say that you are in the Argonne ground. Somebody hits you. Okay? You're shocked. But if somebody tells you, I'm going to hit you, you're ready. You know what you're expecting. So altogether, spend 5 more minutes in explaining the biopsy, and you will save procedure time, you will increase your success rate, and you will reduce the complications. Entry site. Localize the lesion. Decide your needle entry site with a laser. You can place a metallic object to mark the area where you want to enter. Okay? I personally use the same needle that I use for local anesthesia. I calculate more or less the angle of entrance. I see carefully the relationship between the needle entrance and the lesion, and I see if the patient with breathing is doing what I want. That means placing the target in front of my bullet. It's not the other way around. Okay? Other people use radiopaque grids. It's feasible. You can do your own made grid at home, or you can buy one. Local anesthesia is easy. It's not that easy for 2 reasons. First of all, of course, you use sterile technique. You use whatever your hospital is giving you as local anesthetics. We prefer mepivacaine. you have to go down to the pleural surface, but you have to tell the patient that he's going to feel pain. Give time for the anesthetic to work. Many times during biopsies, we give the injection, make the anesthesia, and we start the procedure right away in 30 seconds. You know? Look, do like the dentist does. Give the anesthesia, go and talk with the nurse, comes back in 2 minutes, and then start the procedure. The anesthesia needle sometimes may be very tricky. Why? Because if you, with the tip of the needle, are between the two pleural surfaces, you understand me? Between the visceral and parietal pleura, when you take off the syringe, air will come from the outside ward into the patient. And this is a sort of induced pneumothorax. And this is particularly risky in skinny patients. Why? Because the lung is less than 2 centimeters under the skin. Okay? So what we do in many parts of the procedures, and we will see why later on in another part of the lecture, we use to cap the needle when we take off the mandrels to avoid air entering into the body. You see the cap over here. And you have seen the tiny, tiny pneumothorax over here. Okay, so we decided about the entrance. Patient is prone. Wow, there's no window. It's bad. What am I going to do? Am I going to go from here? Okay, arms down. What happens? Now you have a window. Okay, organs can be moved. Patient can be tilted and moved. Organs shift. Think about it. Okay? If possible, try not to traverse the pleura. Wait a second. The lung is surrounded by pleura. Well, use some tricks. Use, if possible, pleural adhesions. Use, if possible, peripheral atelectasis at the periphery of a nodule. Remember that even if you don't go through the atelectasis, the area of aerated lung that are close to the atelectasis are not so well aerated. So the risk of pneumothorax is less if you go close to the atelectasis, if you're not able to go through the atelectasis. Okay? 1, 2, 3, 4 pleural surfaces you can traverse. The best is 1. So for this nodule, don't do this, because you are traversing 3 pleural surfaces. Do this, it's only 1. Okay? Why do you want to triple your risk? And this is what was done by one of my residents a couple of weeks ago. Okay? This was also a repeat biopsy. Okay? No diagnosis. So this is a large nodule. I see the needle saying, where are you going to do the procedure? Well, I'm going to go through the right middle lobe over here, right lower lobe, right middle lobe, but who's this guy over here? This is the right upper lobe. Okay? And this is the procedure. Do you notice anything? He had pneumothorax. Okay? So the worst possible condition is actually swimming through the pleuras. Okay? Maybe he's eaten 6 pleuras, I don't know. Okay? So what to do? The pneumothorax is not clinically relevant. The lesion is stable. The biopsy is continued. And this is the follow-up at 1 hour. You see there is not increasing pneumothorax. So not clinically relevant. But despite that, an error, a mistake was done. How can we improve our accuracy? Well, first of all, how good is our accuracy? Well, it's highly dependent on the lesion size and on the amount of necrosis. Is that really important? Yes, because we have a range under 1.5 to 2 centimeters where our accuracy rises. Then it stays fairly stable up to a size of 4 or 5 centimeters. And then it goes down because at the same time the amount of necrosis goes up. So what we have to do our best to sample where the tumor cells are and to make the biopsy in that area. we can use different methods. We can use contrast medium injection to aim the diagnostic sample to the living tissue. Let's see this example. This is fairly clear, just to make a teaching point. Remember, this is basic knowledge. This is necrosis. This is atelectasis. So the area that I have to sample is not the necrosis, not the atelectasis, but the area where the living tissue is. So I have to review the imaging done before, and in case, I have to repeat the contrast while I am doing the procedure. So, biopsy, and this is adenocarcinoma. The role of PET is very important. It may be important in small nodules. This was a nodule. I thank Dr. Sabarval from London for giving me this case. This was a nodule which had been there for very, very long time. Then it started growing. So a PET scan was done, and you see that only part of the area, the medial area of the nodule is taking the glucose. So that area was sampled. We had a similar case recently. Look at these images. This is an abscess, okay? This, of course, is a tumor abscess. Where do we do the sample? Do we do the sample, of course, not in the necrotic part? We may do the sample in the outer part, in the capsule of the tumor. What the information of the PET-CT is that the area over here, which are probably the lymph nodes of the right lower bronchus, are the area which is highly cellular, and we did the diagnosis over here. This is a sagittal reconstruction. You see that we go through the wall of the abscess, but we go directly to the bronchi, the area of the bronchi, exactly where the uptake was over here. You see my green arrow. The mediastinal nodes. Mediastinal nodes are always often present in lung cancer, and this brings us away from the lung into the mediastinal, because sometimes we prefer to sample mediastinal nodes rather than a small lung tumor like in this case. Sometimes the lymph nodes are much bigger than the tumor, but they are located in more difficult locations, more difficult positions. So you have to do something anyhow to reach those lymph nodes. So while you think of node sampling or anyhow mediastinal sampling, which is the same, anterior or posterior mediastinum, sometimes you will have to use ancillary techniques and do something to get to the node that you have to sample without risk. We have the vessels in between. We have the pleura, and every time that you go to the mediastinum, if you go through the lung, you cross two pleural surfaces, so you double the risk of pneumothorax. And of course, we have the bones. So vessels you can't go through. The pleural surface, which is in red over there, again, is at risk of pneumothorax. Is there something that we could do? There are several techniques that we can use. The first technique, we have to raise the pleura somehow. Of course, this is an exaggerated picture, but we can use the tiny space, the very thin space that is between the paravertebral space and the pleura to go through it with a needle by doing so. And this is a practical drawing showing what we are going to do. You see that the subpleural window has been widened by this blue fluid, and this blue fluid is saline. You can put some local anesthetic into the saline just to make it more comfortable for the patient, but by doing so, you actually reach the paravertebral space. At that point, you run the risk of not having enough window to go through without injuring the pleura. So you need to raise and open this window with some saline. And at that point, if you stay very close to the vertebral body, and you will feel it while you go on, that you will hit the vertebral body, and as soon as the needle escapes the body, you're safe. At that point, you inject saline solution, and you can reach the lymph node with any kind of needle that we want. Of course, in this case, it's better to use a coaxial technique, but we will get to that in a second. When it gets very, very difficult, and this raises the level of difficulty that you are going to encounter, but is in any procedure, the more you do, the more you feel confident, and the more you lower the threshold of your indication, and you raise the level of your expertise. This lymph node over there is not easily reachable. It was induced pneumothorax, the lung collapse, and you get to the node. I've heard that somebody saying, who? Okay, it's not easy, but it's better to have a controlled pneumothorax, which you aspirate, rather than a real pneumothorax, which you have to drain. Because in an induced pneumothorax, there is no hole on the pleura. The air that you find in the pleural space is coming from outside. And as you have introduced it, you can aspirate that. Okay? Of course, CO2 is better than air. As I said before, organs shift, bone moves, everything can be moved around, you know, the patient and the needle and the target. One thing that you can do when you don't have a mediastinal window, like we have seen in those patients who had lung tumors close to the aorta, you may try to tilt the patient on one side or on the other side. And you may find out that the lung, where the patient is tilted, collapses a little bit, reduces the volume, and you may have a window that you didn't have before. Bony structures. We can go through pleura. We can't go through vessels. Sorry about that. I don't have a tip for going through the vessels. But we can go through bones. Okay? You can go through the sternum. Of course, you will have to use a larger needle to go through the sternum. I have taken this picture from the literature because we don't do that very often. But a couple of months ago, we had this nodule over here, which is right in front of the aorta of the vena cava. So what I decided, well, I don't want to go from here into the aorta of the vena cava, because if I'm coming from the right side, my needle in the throat or in the sampling may go into the aorta of the vena cava. I want to come from this side, but I have the first chondrosternal joint. Okay, that's tough to go through. So I just used a simple Seldinger needle, and you see over here, I use it as a coaxial. You know, Seldinger needles are very inexpensive. You find them in the angio room very easily. Usually they are 18, and all of them carry a 20-gauge needle, okay? And you see this is the coronal reconstruction of my pass, and you see exactly that I am in the joint. Of course, you give extra medication, extra anesthesia, and you ask the patient to collaborate because he will feel a very strong sensation. You know what is the most difficult thing? To stop once you have gone through the joint. Because once you go through a joint and you feel a lot of resistance, when the joint finishes, you are into the aorta. Okay? So you have to go very firm, but very step by step. Okay, and this is again the sample of this nodule. And you see the Seldinger finishes here, and this is the 20-gauge needle inside the Seldinger needle. So this brings me to talk about the coaxial technique. What is a coaxial technique? And then we go through needles, of course, because so far we didn't talk about needles. The coaxial technique is used to obtain multiple samples with one puncture. And in the lung, this is important because it's one pleural puncture, okay? If you do 3 samples with different needles, you puncture the pleura 3 times. So the introducer needle carries a small needle. The most important thing is it has to be a good introducer needle. So a needle where the steel is very thin, so that the size of the devices that they're going to use is going to be increased only by 1 G. That means that a 17 G carries an 18 G. A 19 carries a 20. Okay, so you have to find out very good coaxial needle. Most of them are made by Japanese steel, which is very hard and very thin. These are different kind of needles, and this is again an example. This was an area of lung consolidation, which was not clear if it was pneumonia, it was tumor. So we did a couple of samples with the coaxial system, and this was bronchoalveolar carcinoma. So it comes to needles. As you have seen, I arranged this lecture the other way around. I didn't start from needles. I started from talking with the patient, which I think is the most important thing when you do a biopsy. Of course, we have needles which are small needle for fine needle aspiration biopsy. There are the Chiba needle or any other kind of needle for cytology. I would not go in depth into this subject, otherwise it will be a lecture on needles, which is not something that we want to hear now. So you can get cytology. But as we say that most of the time in these patients, if they are not operable and they will not have a definitive histology, you will never get a definitive histology. You need to go for histology with your own needle, okay? And wait for the phone call of the pathologist saying, look, I have good material. So you have to decide what kind of cutting needle you're going to use. You have TrueCut type of needles. I guess that all of you are familiar with that. I guess that those of you who do breast biopsies are very familiar with those. And they are in a size that goes from 16 to 22. I have never obtained tissue with a 22. So I don't know why 22 is on this slide, but anyhow, the manufacturer do it. They come in automated devices like guns for biopsy. They're very comfortable. The only issue is that they're very comfortable when you do ultrasound-guided biopsy because you hold them in your hand. When you do CT-guided biopsy, you have to attach them to the needle once you are in place, which is a kind of tricky. And I would warn you to train yourself a little bit on a turkey before you do a human. And then there are semi-automated sampling devices. They are lighter. They don't have the steel gun, so they can be used safely in CT. And as you can see over here, you can detach the stylet from the cannula. Okay, over here you see there is a sort of lure lock system over here. And this is very useful because not only will help you during the positioning of the patient, but in case you want, you can use and leave the outer cannula in place while you retrieve the stylet with the sample, and then reintroduce only the stylet. It's a sort of semi-type of coaxial technique where the cannula works as a coaxial for the stylet. And then one of very popular type of needles are the modified Mangini needles. These are needles where a very sharp cutting tip is equipped with a mandrel and with a syringe, and the mandrel is attached to the syringe. So at the same time you have removal of the mandrel, increase of pressure, and exposure of a very, very sharp tip, which will sample the tissue. What is the difference between the end cutting needles and the side cutting needles? So between this and the TrueCut type of biopsy needles that you use for the breast? Well, is that if you look at the front view of the needle over here, you see that in the side cutting needles, half of the cannula is taken by the stylet. So there's no tissue there. Okay? It's like when you go on a boat and you have a cabin for two and you have somebody else in the other bed. He's taking space. You don't want him. You want the cabin for yourself. Okay? While with the Mangini, the whole cannula will be able to host the sample. And this is the type of sample that you get with a modified Mangini needle. How good we are if we are able to follow all these advices that I'm giving you, because these are advices. Well, we should be very good. I brought you a couple of reviews. This is about 631 needles. And you see that altogether, in this literature review of this group, the accuracy was 95%. What were the factors affecting the accuracy? Lesion size. It's easy to understand. It's more difficult to hit a small lesion in a very consistent way, and the necrosis within the lesion. What's interesting, if you see at the practice among the 5 radiologists involved in the study, with A being the most experienced and E being the least experienced, you see that the most experienced used mainly 20 G needles, while the least experienced, which was probably a resident or a fellow, used a lot of 18 and 16 gauge needles. It looks like that non-experienced people feel more confident if they use larger needles, which are easier to operate, easier to steer and to guide, and get more tissue, rather than with small needles. You already have seen these slides. This is another series, a series from Europe, and you see again that altogether the sensitivity was 92%. That means that 1 out of 10 will be a repeat procedure. This is something that you have to accept it, and the patient has to accept it. When you talk to the patient, you can tell him, look, approximately 10% of the patient have to repeat the biopsy because the first sample is non-diagnostic. This is part of the game. It's not my fault. It's something that happens, and we, me and you, have to accept it. And again, if you see, the most important factor was, again, nodule size as of accuracy. Post-procedure care, simple, bed rest, supine or lateral decubitus according to entrance site. You check O2, pulse, blood pressure monitoring, and according to the different praxis, you keep the patient 1 to 4 hours near you in a dedicated recovery area if you are rich enough to have a dedicated recovery area. A routine chest X-ray can be performed at 4 hours. Other groups do a chest X-ray only if clinical deterioration is appreciated. Now, many services perform lung biopsy as a day case with discharge at 4 hours and readmission only in case of symptoms. Why? Because this is what you want to avoid, the pneumothorax. And this will lead us into complications. No matter what you do, you will have pneumothorax, okay? So this is something that you have to accept. Like I said, the repeat biopsy is something that happens, okay? In this review from the University of Stanford, they had a 27% pneumothorax rate. And then they found that the significant independent risk factor for pneumothorax were the needle size and the patient age. Don't believe them. All of these count. If you read the whole literature, if you talk to other doctors, if you talk to people who have experience in lung biopsy, you will find that all of this has to be taken into account, okay? Underlying COPD, it's very important. Patient age, because of the COPD and because also the corroboration. Needle size, lesion size, of course. Lesion depth, if they touch the pleura, of course, risk is 0. No previous surgery, of course, because if they had surgery, they have pleural adhesions. The procedure time and the operator experience. When you go into a CT room and you see that your residents are still doing the procedure and they are at the 29th or 32 series, so they didn't reach the nodule in 32 scans, something is going on. And then conditions that suddenly increase the chest pressure. Patient coughing and patient has a tracheal cannula. So we try sometimes to sort, this is not scientific, something that we do in our practice. We try to study the lung parenchyma looking for bulla in the needle tract, not just generically COPD, but bulla in the needle tract, presence of bronchiectasis, comorbidities and other conditions, and we try to stratify the patient as a low risk or zero risk, can be done in daycare. Mild risk can be done in daycare if an experienced person does it or if there are other needs, and high risk where I do prefer admitting the patient to the hospital. Because no matter what you're going to do, you're going to have pneumothorax. And some of the pneumothorax you have no treatment. Some of them you will treat them just by simple aspiration, but some of them will end up with a chest tube. And the rate of chest tube placing changes from place to place according to the threshold for chest tube placing. And we'll see that in a minute. This is a sort of algorithm. I hope you are able to read it. It starts with lung biopsy. Then you have pneumothorax. If it's small, you can aspirate it. Then you go into the cascade of events, okay? And if it's symptomatic or is more than 30%, you will place a chest drain and so on. I don't want to go in deep into this slide because there are a lot of argument about this. The only message that I want to send you, to give you, is that whatever you do, you're going to have pneumothorax. Whatever you do, you're going to place chest tubes. But please try to avoid over-treating non-significant pneumothorax. Observe them, send a note to the ward, call the referring physician. If you are changing the shift, ask for collaboration of other, radiologists. Would you mind to check this patient for me and let me know what's going on? But don't place a chest tube just because you feel more safe in placing a chest tube, because it hurts. It hurts and it prolongs the hospital stay, so it's more expensive. This is a pneumothorax, for sure. No symptoms, the lesion is stable. What would you do? Would you finish the procedure? I think so. Now, it's increasing. You have done the biopsy, you have done the pneumothorax, now somebody has to treat this pneumothorax because it's increasing and the patient is rather symptomatic. So, possibly, you place the tube under fluoroscopic guidance, you or the surgeon. If you see pulmonary expansion, of course, you can discharge the patient. If not, you will have to start mechanical aspiration. How do you judge the pneumothorax? I guess that all of you know this slide. Remember, anytime that you have a pneumothorax, at least what I do, if I have the pneumothorax in CT, and I have made a diagnosis of pneumothorax in CT, then I take a chest X-ray. Because in the afternoon, we try to do all the lung biopsies in the morning. In the afternoon, or the morning after, to check the chest X-ray, somebody will do, to check the pneumothorax, somebody will do another chest X-ray. So it's better to have a baseline pneumothorax after the end of your biopsy, rather than having somebody else guessing has increased, has not increased. Who places the chest tube? You can place it yourself with the Seldinger technique. If you place it with the Seldinger technique, you have to remember that you will have to follow the patient on the ward. You will have to make notes on the chart. You will have to make tube malfunction, and then you will have to sign for discharge. Do we as simple radiologists have the time to do that? If you are able to do that because you are in a service with 4 staff physicians and 5 fellows, that is something that you can afford. Unfortunately, in our hospital, we cannot afford that. So we are in very close relationship with the thoracic surgeons, and we manage the patient together. That doesn't mean that everything goes well every time. This is the same patient. Chest tube placed. I'm not sure if you can see it. Patient breathes better, but he has a horrible chest pain. Why is that? Chest tube is here. It's again the sternum. In between the sternum and the heart. I hope it's not in the pericardium, of course. So we had to replace it, and the patient feels much better. This is the regular positioning of a chest tube. Other complications that you have to warn the patient: hemoptysis, hemorrhage, failure and need to repeat, and rare complications like sepsis and air embolism. Hemorrhage is very often non-symptomatic. It's self-limiting and intraparenchymal. The most important thing, you have to warn the patient that if he has hemoptysis during the biopsies or right after the biopsy, he shouldn't be worried too much. He starts saying, "Doctor, I feel something strange because this is the taste of the blood in the mouth. I feel something strange, I have to cough." And then you give him a gauze and you see the blood. So you have to reassure him. Most of the time it's self-limiting. Of course, you have to inform the referring physician and the ward because you may need closer monitoring of this patient. Sometimes a little bit of hemorrhage around the nodule may actually reduce the risk of pneumothorax because the blood will go into the tract and coagulate the tract instead of air if blood goes into the tract. And actually, there is a company who has marketed a closure device where an hydrogel plug is left into the tract and actually avoid air to escape the lung and to go into the pleura space. There are studies published on this, and these studies claim that the pneumothorax rate is reduced, also the number of chest tube placement, and if you place less chest tube, the cost of the plug is offset by the reduced cost of less days into the hospital. And of course, there were less post-biopsy admissions. A rare complication that I am mentioning here because it will really scare you to death when you have that kind of complication is anybody in this room has had an air embolism? One. How did you feel? Bad. The air embolism is something that happens because you do an inadvertent puncture of a vessel, and the air can go into the vessel and therefore in the systemic circulation by two systems. Either when you take off the mandrel from the outside into the circulation because it's aspirated by the negative pressure of the atrium, or you traverse a vessel and a bronchus, and then because of increased pressure in the chest, actually air embolize into the systemic circulation. The symptoms resemble those of stroke, TIA, seizure, cardiopulmonary collapse. Anytime that you have a patient who was feeling best, well, before the procedure, and all of a sudden it becomes strange, unconscious, he rolls over his eyes, you have to think about air embolism. At that point, you do redo a chest CT of the chest and the brain. Where is that blood? Right ventricle. Where is the, that air, right ventricle. And this one is in the brain vasculature. If that air goes into the coronary arteries, you can have also a myocardial infarction. So once, remember, cap your needle. What do you do? Well, first of all, you have to make a diagnosis. If you make a diagnosis, you place the patient in the left lateral decubitus with the head down. You give him 100% oxygen or hyperbaric oxygen, and then you call ICU. Okay? You can have a fatal air embolism. Patient can die of this. Most of the patients resolve with no symptoms or no sequelae, and actually people say that this is underdiagnosed. There are much more air embolisms that we know. So, I want to close this lecture with some take-home points. And the take-home point that I decided to make, because I was asked also to summarize the lecture, is that you should have a checklist. You should have a checklist of the things that you should do every time you do or approach to do a biopsy. And this checklist is exactly the same list of items that you have seen at the beginning. You have to remember that never, 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 never schedule a biopsy without reviewing the imaging. Balance indications and contraindications. Select what is the best guidance for you. Talk to your patient. Talk to your patient and get the collaboration. Remember that good positioning may be everything, and of course, a good, well-done local anesthesia is important. Know all the biopsy techniques and all the ancillary techniques to get to your target. Be able to manage the recovery period and be organized to manage all the complications. And hopefully, you will not have complications. Thank you.